Hello, thank you for joining us for our Fibroid Awareness Month premier event, Fertility and Fibroids, the impact of fibroids on well-being and maternal health. We will focus on the many aspects of reproductive health and will address treatment options to maintain fertility, discuss what to be aware of during a pregnancy with fibroids, birth control in fibroids, and much more. Our hope is that this information will help you to be more involved and knowledgeable when you are discussing your treatment plan with your provider. I have an outstanding group of physician partners joining me for this discussion. They are Dr. Raymond Anshin, Brigham and Women's Hospital, and assistant professor at Harvard Medical; Dr. Soni Singh, the Ottawa Hospital, Ottawa, Canada, and professor at University of Ottawa; and Dr. Elizabeth Stewart, gynecologist and reproductive endocrinologist at Mayo Clinic. Welcome you all so much for joining me.
Thank you.
Thank you.
Thanks.
So I'm going to start off. Our theme for Fibroid Awareness Month is Real Solutions. And so our goal is to share your expertise in helping our community members to navigate their care and to have some real tangible takeaways. So Dr. Anshin, I will come to you first with the first question. It is, I'm trying to conceive and have one or many fibroids in my uterine cavity. What is my next step?
Thank you, Sotero. That's a great question. Just for the listeners, fibroids, just a little bit of background. Fibroids are basically a growth of a single muscle cell that have a mutation. They can form a non-cancerous tumor, and this lesion can distort the shape of the uterus. So clearly, when I say these things, what comes to mind is the location and size and the number of fibroids are important when answering this question. To give a little bit of background, a fibroid can be located on the surface of the uterus. It can be located in the muscle of the uterus, or it can be located in the cavity. When you're thinking about reproductive health, we're probably most concerned about the uterine cavity. And we want to be sure that it's tremendously distorted or to the point where the lining cannot get thick. And so when patients come in complaining of fibroids, and we get these consults all the time, I'm sure all of us here on the panel get these consults. One of the first things to do is get a good idea of where the fibroids are, how many there are, and where they're located. To many of my patients' surprise, a lot of these fibroids don't need to be treated if they are small fibroids and outside of the uterus. And the ones that are of most concern are usually the ones that either interfere with the lining of the uterus or obscure the lining from being seen or growing. A second way these fibroids can impact it is if they're blocking the opening of the fallopian tube, and therefore you difficulty with getting the oocyte to travel into the cavity. And obviously, a much debated area has been, do fibroids in the cavity cause an increased risk of miscarriage? And there have been several studies, and there's conventional wisdom in this. So when you see a patient, the first thing that I try to do is get a good imaging study, in addition to a good physical exam. And one of the things I find is it depends on where you're practicing. You may have excellent ultrasonography, where you may be able to see the images of the fibroids clearly with three-dimensional ultrasound, or you may need an MRI. But ultimately, once you identify the fibroid and the location and the number and the size, the discussion comes to how and will this impact fertility. I think a very interesting study that came out around 2017 from Vanderbilt by Dr. Kathy Hartman and colleagues looked at over 5,500 patients, and 89% of them did not have fibroids, the rest did. Interestingly enough, the miscarriage rates between both groups was comparable, which really challenged the conventional thinking that taking out fibroids may improve pregnancy outcomes across the board. However, I think it's still true if you have a intracavitary submucosal fibroid that's causing severe distortion or bleeding, that the best approach is to address this. And the question then, I'm sure that the Satira is going to get to this, would be, how do you address this? Do you remove the fibroid? And how do you remove the fibroid? And you have to balance your approach to treatment with what happens to the uterine cavity after treatment. Some treatments can be fairly aggressive and cause scarring and may compromise the integrity of the uterine wall. And so then patients who are pursuing fertility would be concerned about how would this impact them carrying a pregnancy and delivering a baby. And without getting too much into the treatment aspect, in patients who we have extensive removal of fibroids by surgery, in our practice, we often counsel them to wait at least 3 months before trying to get pregnant, because there is a concern about having uterine rupture during a pregnancy. So ultimately, to kind of crystallize it, the way a fibroid can impact it is either by blocking fertility, by blocking the tubes, interfering with implantation, or by interfering with the growth of the embryo later on. I've had patients with so many fibroids that their endometrial lining is very thin, and these patients are often a difficult group to treat, because even when you remove the fibroids, due to the scarring, you may not get a healthy endometrial lining later on, which is really the bed where the baby would grow in. I'd love for Dr. Stewart or Dr. Singh, if they have any comments, to jump in and share them. When you think about the locations of the fibroids, the ones that are in the muscle underneath the top of the uterus, I've had patients with fibroids as large as 7 centimeters, which is fairly big. It's like the palm of my hand. And these patients have gone on to have normal pregnancies and deliveries without having any intervention at all. And so not necessarily just pure size, but also where within the muscle and where within the structure of the uterus these lesions are located.
Yeah, I would agree with what Dr. Anchen says. The one thing I usually add to that is you should make sure you have a full fertility picture before you make a fibroid plan. Because before you go in and have fibroid surgery, you should know, are my ovaries functioning normally? Has my partner got good sperm, or have I got a plan for donor sperm? That you want to be thinking holistically about fertility. And then put it together with your fibroids, because you might have plan A for fibroids if that's the only issue you're encountering, and plan B if you also have bad ovarian reserve and bad sperm. So think about fertility as the important part, and fibroids as a potential fertility issue.
That's a really excellent point, and I think it also plays into how you plan treating the fibroids. Sometimes when I see a patient who's very committed to fertility and having their child, but they have a low ovarian reserve, which means they have low fertility, I encourage them to consider going through fertility care before they manage their fibroids, because that could significantly delay them from trying to get pregnant. And as Dr. Stewart correctly points out, you don't want to spend 6 months treating fibroids only to find out that meantime their fertility has continued to drop.
All fantastic points. Dr. Anchen, I have a question for you on hormonal therapy that someone who's trying to conceive might be taking. What considerations should there be on stopping the hormonal therapy before trying to conceive?
That's an excellent question. So hormones can be very helpful in treatment of fibroids, but in the context of fertility, we must also understand that the hormones can impact the response of the ovaries, depending on what we use, and it can also impact the development of the lining. So, for example, when I have patients who have a progesterone IUD, I caution them that when they want to start trying to get pregnant, that they would need to stop their hormones in advance and give their lining a chance to recover. Some of the treatments for fibroids that are hormonal may involve including increasing your progesterone or suppressing secretion of estrogen using something like a gonadotropin releasing hormone agonist. And the problem with these treatments is they also impair fertility. Unfortunately, you cannot do them concurrently when you are trying to get pregnant. since we can essentially keeps you from ovulating and allowing eggs to mature. So, I would say typically the approach has been in the event that someone wants to treat their fibroids, has been a surgical approach. I don't know if Dr. Stewart and Singh agree with me, but I think that's what I've seen mostly.
Okay. And Dr. Stewart, would you expand a little bit more for our audience on ovarian reserve and AMH? Because for most patients, those are topics that are not familiar, and they can be very critical when you're considering conceiving.
Yeah, great comment. So ovarian reserve is really the quantity of eggs that a woman has available to ovulate. And although all the diagrams we've ever seen show one egg developing every month, actually your body gets a whole group of eggs ready about 3 months beforehand. And so since women have all of the eggs they're ever going to have before they're born, the number of eggs you get ready in your 20s is higher than the number of eggs you get ready in your 30s, and is significantly higher than the eggs you have available for when you're in your 40s. And so finding out what your natural egg supply is at that particular age is an important determinant of fertility. And AMH is a hormone called anti-Mullerian hormone, and it's made by the small eggs there that are ready at the start of the cycle. It's a very good predictor of fertility potential for women who have infertility. It's less clear that it's a good predictor if you've never even tried for pregnancy, but I think that's why we've all said that when you're thinking about a fibroid plan, you want to be thinking in terms of the whole fertility picture. Do you have a good egg supply? And if not, that may influence your fibroid plan. So I think it's a really important landmark that you need to know if you've been having trouble getting pregnant or you're thinking about fertility care for fibroids.
Thank you for that answer. I have one more follow-up question, and then I'll go to Dr. Singh. Dr. Stewart, how should people frame their family history when it comes to looking at AMH levels and fertility? Should they assume that they will be the same as the other female members of their family, or is fertility really an individual case-by-case basis?
Yeah, great question. So your family history has a very small influence on your fertility. That again, that there is some influence, but it's small compared to other things that you've experienced in your life. So even if you have a great family history of fertility, if you've had chemotherapy for cancer or drugs like methotrexate for rheumatologic problems, that's a much bigger impact. Again, there's a role of family history in fibroids, but not everybody with a family history ends up having fibroids. So I think that you can't really be swayed either way. You can't say, well, my mom had me when she was 48, so therefore I'll have good fertility. And you can't assume that because your mom had long-term infertility, that you're going to have problems. That again, medications you take, other medical history you have, and exposure to infectious diseases plays a role. So there's a lot of influences, and family history is a small one, but not the major determining factor.
Thank you for clarifying that. I think that's really an important consideration for everyone. Dr. Singh, I'm coming to you to talk about myomectomy. It still is really one of the top concerns of our community, seeking the right provider for a myomectomy. And we usually receive a communication from a community member who has one or I'd say less than 5 fibroids who's being told that hysterectomy is their only option for smaller fibroids. So my first question to you is, how should our community members go about selecting a provider to perform a myomectomy if they determine that that's the best course of action?
Well, thank you very much for having me on this panel. It's been great learning for me as well. And the most important teachers are also the patients and your community, because we get good feedback. And if this is an important question, we need to address it. I think one of the ways to answer this is also to acknowledge a couple of the educational tools that we have delved into, which is each patient's story is unique. Just like there are many fibroids that could be in many locations, the journey that each patient goes through is very unique to them, whether it's their fertility issues or their symptom issues. And I think each patient then has a unique plan that needs to be discussed with their provider and their family so that they're on the same page. I think that is probably the best place to start. Do you have somebody you can connect with who you feel has heard you out, has acknowledged your wishes and desires for fertility, managing the symptoms, and is able to consider those aspects? We often forget that bedside manner is as important as the surgical skill. So I think the start is the person on the other end listening to you, and I encourage you to advocate for yourself. Sometimes it's miscommunication. Maybe there was a misunderstanding as to what the goal was or why you were there that day. So I think it's important to advocate. I'm here because I really want to get pregnant. This is my goal. How, can you help me? Or my bleeding is really bad and I want to get pregnant. Can you help me? Or what are some of the other options? So I think that connection is vital. Number two, a lot of the focus has been on surgical skill when we talk about this. And again, as I mentioned, surgical skill alone isn't the only thing that you should consider. It's all about planning and prep work. So as was mentioned earlier, the importance of getting good quality imaging. We don't work in a silo. So do you have good quality imaging with a radiologist who you trust, or the imaging modalities that let you plan? Fertility specialists are part of that group as well. So I think when you go, you have to see from the perspective of the larger picture, does the surgeon have a team, and are they prepared and planning appropriately? And then finally, the surgical techniques. And we do, like I said, spend a lot of time on this. The myomectomy procedure can be done in many ways. And it's important to recognize that it's not the tools that are used, but rather the surgeon and their skill set. And I think that when we have that discussion, it could be a robotic myomectomy, could be a laparoscopic, hysteroscopic, or even a laparotomy. If you've got 30 fibroids that need to come out, most of us would understand that you need to do what we call a laparotomy, or a bigger incision. But if you've got one solitary fibroid that needs to come out, then their laparoscopic approach or the hysteroscopic approach, depending on the location. So in summary, trust your gut, have a good connection. Number two, evaluate the team approach, the planning, the preparation. And finally, feel free to ask, have you done many of these? What is your approach? Or can you help me find the right person for what I need?
That's fantastic feedback. Thank you so much for that. And I talk about bedside manner probably ad nauseum, but it is so important. And I really think that bedside manner then makes it easier for you to advocate for yourself, because you feel like you have a sensitive ear, and it makes the whole process of shared decision-making work so much better. So thank you for pointing that out. I know that many of our community members and many women and menstruators undergo multiple myomectomies in an effort to conceive and to alleviate symptoms. Is there a limit to how many myomectomies it's safe to undergo, or is that also on a case-by-case basis?
It's a really tough question that I think all of us see quite often, because this is increasingly becoming an issue, because now we have the skill set and the awareness of how to move forward with not just surgical options. We should mention there are interventional options as well, and medical options. But when it comes down to it, I really have to remind myself and my colleagues that it's about individualizing the care. So when we talk about repeat myomectomy, for example, in a complex hysteroscopic case where the fibroids are coming into the uterus, where pregnancy will eventually take hold, you may need repeated hysteroscopies to really make sure that you safely remove the fibroid without hitting the line or injuring the lining. But when it comes to multiple myomectomies by laparoscopy or laparotomy, it can sometimes be very tough. I'll be very honest with you, Sateria, and your community. We are being asked in many cases, because all of us see probably the extremes, of really taking on difficult, challenging cases. And when I see someone that has been had care from a trusted colleague where they've taken out 10, 15 fibroids, it's really tough to counsel a patient to understand that it isn't just the surgical skill, but it also is the scarring that's occurred, the risk to the uterus, and other factors. So we can be as great as we are as surgeons, and have the best hope from our patients, but there are limitations as well. So back to individualize the care, and ideally one myomectomy is better than multiple myomectomies. But if it is multiple myomectomies, back to what is the goal, what is the outcome, and being honest with our patients as to what may come of that. I don't know if anybody else has a comment from that perspective. This is a tough question.
I just want to follow up with what Dr. Singh and agree on that. I just recently had the experience of doing a couple of repeat myomectomies on my patients for fertility purposes. And Dr. Singh is correct. On the repeats, the scarring was horrendous. The bowel adhesions were extensive. And I anticipated this. I brought in a oncology colleague into the operating room with me. But just taking down the adhesions took up a bulk of the surgery. And if it wasn't for the goal of fertility preservation, I would not have even attempted it. And it went well in the end. But that's on someone who had just 2. So I can't even imagine what will happen if they have more than that.
I would agree with what's been said. I think, again, it has to be individualized, because if you're doing 2 myomectomies 10 years apart for somebody who was very happy for 8 years and then has a new fibroid, that's a totally different situation than if somebody had a procedure just a year ago, it was well done, and the fibroids are already back. I think also with recurrent fibroids after myomectomy, that's one of the times to think about some of our other modalities of treatment. Is uterine artery embolization an option, or medical therapy? Because again, many women and providers gravitate to myomectomy as being the best option to optimize future fertility, but I'm not sure a second or a third or a fifth myomectomy is as fertility optimizing. And so again, if you have scar tissue, is uterine artery embolization a better technique for a woman, because the treatment goes through the blood vessels and you don't have to take care of the scar tissue before you get to the fibroid. So I think that we don't have much evidence to guide us, because most of the evidence is based on having a single intervention. And there's such a range of types of surgery and types of fibroids that you really just have to sit down and weigh the risks and the benefits and individualize, as Dr. Singh says.
And Sateria, if you want one last internal little tip that patients wouldn't hear, your community wouldn't hear, when we teach our residents and fellows, we often say, a good surgeon knows when to operate, and a great surgeon knows when not to operate. And that's not a dialogue that your community may hear very often, but I think it's harder to know when to stop during a myomectomy, because you may potentially harm the uterus for fertility. It's also harder to say no. And so I think that is where the real challenge in surgery comes, is really balancing the risks and benefits. That's a little insider part that we may be discussing, in the background. But that to me is really the goal we all, aspire to, is knowing when to make the right decision at the right time.
And I think all of this feedback and your latest statement, Dr. Singh, is what really is going to help to empower our community and reassure them, because they have many considerations to make, but to know that that type of care does exist. Some of them have not seen that type of care. And I'm one of those patients who had fibroid symptoms return less than a year after having an open myomectomy. And it was just unfathomable to me to undergo that surgery again. So there are so many considerations to make. And I think one of the things that we don't have data on that, correct me if I'm wrong, that you alluded to is that you need to think about your life and health beyond your reproductive years, with the surgical or treatment options that you select. I think that should be a consideration, even though we don't have that much specific data on that as well. So
I agree. And I think also there are lots of other family building options. So even if your goal is to have a family, that surgically optimizing the uterus may not be the only way to go.
great point. Thank you. So Dr. Stewart, I'll come to you regarding pregnancy. If you have fibroids growing while you're pregnant, what considerations should there be there, and what should someone ask their provider if that is the case?
So I would say, first of all, don't panic. The uterus is growing tremendously. And so it would be surprising if the fibroids didn't grow. And studies have shown that during pregnancy, about a third of the fibroids grow, about a third of the fibroids stay the same size, and about a third of them shrink. So just to have the ultrasound technician or the doctor say, oh, your fibroid's growing too, it may be in proportion to the uterine growth and the baby's growth. So it's not necessarily something to panic about. The other thing is there does seem to be a tendency to maybe see fibroids more readily as the uterus stretches to accommodate the pregnancy. Maybe some fibroids that were less visible within the myometrium are now popping up toward the surface and being able to be measured better. So it could be an artifact. That although we see many fibroids grow during pregnancy, it's a very, very small proportion of women that have a major problem due to that. That again, sometimes it can be pain. So the fibroids can grow so big that they outgrow their blood supply, and you can get severe pain. And rarely we even see women that have to come into the hospital to have pain management for that. And there can rarely be fibroids that grow and cause problems with the pregnancy or the placental growth. But I would say for most women that have growing fibroids during pregnancy, that it's not a typical concern. And as long as you're feeling good and the baby is growing appropriately, it's usually not a source of concern. But I'll open it up to my colleagues as well.
I think that that's excellent feedback, and not panicking and maybe taking a deep breath is also a great way to start off. And my last question is, are there emerging fertility-related research or treatments that you'd like to share with our community that might not be as widely well known, that we have not covered in this conversation?
So I would take it one step back, because I know the other two guests here are much brighter than I am, so they're going to have all the up-to-date. I'm going to go back to the fact that we haven't actually studied enough on some of the very important topics we've already talked about, which is preoperative planning and counseling. And that's where some of the research and work needs to happen. So how do we get better imaging in the hands of the entire community in general? And so teaching and doing what we call knowledge translation. So we just talked about, how do you figure out where the fibroid is? Where is it located? How am I going to plan my surgery? And so that I can have a uterine sparing procedure that allows for a pregnancy. And so I think there needs to be more investigation there. And again, I'm talking about work we're doing with our 3D modeling, using virtual reality, planning things accordingly. So I think we have a lot of work that doesn't have to be new and emerging, but is to spread that around the world in a way that allows people to adopt that basic education of get a good quality ultrasound that tells you where the location is, and then have the surgeons understand the imaging and plan the surgery around that. And it amazes, I think, all of us on this call that is still missing, I think, in the majority of the locations around the US and Canada for sure.
Thank you for that answer. I think that that's another very important point to make, because imaging for me was critical, as it is for many, many, many patients. So thank you for sharing that.
I think imaging is important, and then timing is also important. That again, it's heartbreaking when you've done an abdominal myomectomy on somebody, and then they're not ready to pursue pregnancy, and by the time they come back and are thinking about pregnancy, they've got new fibroids or regrowth of old fibroids. And so I think the thing that I've been using more in the past 2 years is there are newly approved drugs called oral GnRH antagonists, and they're approved to treat heavy menstrual bleeding for 2 years. And so if somebody thinks that they're about 2 years or 2.5 years away from thinking about pregnancy, it can be a great holding strategy. It can relieve their symptoms and get them through the end of medical school or through their, dietary internship or whatever career goal or personal goal they're trying to get through. And then even though it is not a long-term solution and the person may still need fibroid surgery or other fibroid intervention, if you can time that so that you say, my fibroids are optimally controlled now, let me get pregnant. And if I'm having trouble getting pregnant, I can do fertility treatment. To be looking at that temporal relationship, I think is important.
Thank
So,
you.
Chair, just to go back to your question,
Okay.
I'm sorry, just to go back to your question, I was going to say there's a lot of exciting stuff coming down the pike. And one of the things I think Dr. Hartman's study that I alluded to revealed is how much we need to know about treating fibroids, because we have a lot of conceptions that may not be accurate. And, Dr. Stewart's been a leader in the field of ultrasound-guided focused, looking at focused treatment of ultrasounds, of fibroids, I'm sorry, and looking at other interventions and seeing the impact on fertility. Urinary embolization was mentioned. There's more studies coming out to show what the impact is for urinary embolization for fertility. So we may find that we have other approaches that'll actually be also useful in lieu of myomectomies. Additionally, while we tend to go towards myomectomy for improving fertility, again, this is a study that Dr. Stewart is leading, looking at how does the approach impact ovarian reserve. By taking on fibroids, we think that the general feeling is that no, we're actually helping, but we may actually be diminishing ovarian reserve, but depending on the location, the size of the fibroid, by maybe changing the vascular supply to the ovary or whatever may be the approach. So I think this is all new knowledge that's going to be upcoming. There's a relatively new technique called the Sonata, which uses radio frequency. Again, I was just looking at a paper recently where they're looking at how does this impact fertility. They're accumulating more data showing that people have been able to get pregnant after this approach, which is another minimally invasive treatment for fibroids. So patients may find that they may not have to get these multiple myomectomies in order to get pregnant, or they may not even need a myomectomy based on where the fibroid is.
Very useful information. Thank you all so much. Dr. Stewart, Dr. Anchin, Dr. Singh, I appreciate you, our community appreciates you, and thank you so much for being with us today.
Thank you for doing what you're doing for women with fibroids. It's an important field.
Thank you for inviting us, Satara.
Thank you in the community.
This has been a fantastic start to our Fibroid Awareness Month educational programming. I've learned so much from this discussion, and I hope that you have as well. Once again, thank you so much to Dr. Stewart, Dr. Anshin, and Dr. Singh for being on this panel with us today. Your wealth of knowledge helps our community so much. Also, a special thanks to our platinum sponsor, AbbVie, and our gold sponsor, Myovant Sciences Pfizer. Your support allows us to provide this much needed programming. A big thank you to our community who is joining us today. We hope you can join us again next Thursday, July 14th at 7 p.m. Eastern for From First Flow to Last Flow, where we will discuss the menstrual journey from the teenage years through menopause. Be well, everyone.